Early on in the management of sepsis, we know that patients are often going to be tachycardic as a response to fever, hypotension, and vasodilation. That tachycardia is a compensatory mechanism to increase cardiac output and increase perfusion. But as we resuscitate the patient, give them fluids, start them on vasoactives, drop that fever, we should see that tachycardia improve. There are some patients that have persistent tachycardia, and that can result in myocardial dysfunction. The idea here is that some patients with sepsis and septic shock have an exaggerated sympathetic response, and that can lead to both systolic and diastolic dysfunction. And so now we're adding cardiac dysfunction to the patient who's vasodilated and hypoperfused. In these patients who are adequately resuscitated with an exaggerated sympathetic response, we should consider beta blockade with Esmolol. Tamping down that tachycardia can improve myocardial function, and that's going to help the patient to recover. The data for Esmolol has been around for a while and has shown an association with improved 28-day mortality. In considering Esmolol for sepsis management, it can't be stated enough that this is not something we should be reaching for early. This is only something to consider when the patient has persistent tachycardia after adequate resuscitation. But in that situation of persistent tachycardia, we should consider adding beta blockade with Esmolol to improve cardiac function.